So first off, we're here to talk about hormones. This is a subject that I'm very passionate about and very excited about, but also a little concerned just because it's such a vast topic. And to run through this with trying to get as much information to you guys as possible to give a very good overview of hormones and where we are and how it can work towards longevity and vitality is it's a concern just because there's a lot of information. So I'm going to try to give the best overview as I can and hit the biggest points possible without getting too deep into any of the subjects and then leave some times for question and answer. But most importantly, we want to touch on some of the science, some of the recent conversations in the media, and then talk about safety and solutions, and hopefully how you guys can find ways to add hormones and either add them into your current existing practice or expand on them if you're not doing them yet. So myself, just a little bit about myself, just so you guys understand who you're getting the information from. So I'm a medical doctor in Clearwater, Florida. I've been practicing functional medicine my whole life, not my whole life, my whole career. But I have the unique experience that I did not practice in a traditional medical practice. So I was in residency, realized that traditional medicine was not the path I wanted to take. And so as soon as I exited residency, I jumped straight into functional medicine and concierge medicine, and that's really all I know. And so I've written a couple books, spent a lot of time. I have some expertise in a lot of different modalities, medical detox, psychedelics, hormones, fitness, nutrition, sleep, pretty much anything that can contribute to vitality. And so it's exciting for me to be able to talk about this because it's something that I'm passionate about. I am the CEO and medical director of My Practice Connect. I think Shelly's going to talk a little bit at the end about how our application and how our company can help people that are interested in that need support or interested in evolving into functional medicine or expanding into hormones specifically. We have a lot of tools for that, and we're obviously this is what we do. We try to help more medical practitioners get involved and get this involved into their practice models. So with that said, let's get started. So right up, in the beginning here, I put this statement: aging is inevitable and decline is optional. I think Stephen was actually, who's on this call, was the one that brought that statement up, which is really what kind of sets the pace for this conversation. Again, aging is inevitable, but decline is optional. And so once we start getting into that conversation, we realize that hormones in replacing hormones and optimizing hormones is not just about correcting symptoms or managing disease. It's about vitality. It's about doing more than just getting by. And when we understand that, you also realize that hormones alone isn't a way that this is going to happen. I mean, this is a multidisciplinary effect that you're going to be looking at when you're really trying to get on a path of longevity and vitality. And so we never overlook the other contributors, which is lifestyle, sleep, diet, exercise, and then hormone optimization, and then micronutrient corrections. When you do all of those together, you can find yourself on a path for longevity that you would not be able to achieve had you not enhanced your lifestyle or started looking at optimizing or replacing hormones. So again, there's no magic pill, and this is a great time to have this discussion because I think at this moment there are many clinicians out there, but also consumers that really believe that GLP-1s might be a magic pill. And I'm hoping that with medical logic that we don't think of that as being possible, because I do not believe that there ever will ever be a magic pill. And once you hear and understand what happens with hormones, you're going to see that that's just impossible. There are just too many moving parts, and there's just too complex of a system that we have to think that there's one solution, one pharmaceutical, or one lifestyle factor that can put us on that path that we're looking for. So just understand that. So as we get into this now, we're talking about hormones. And so hormones are kind of considered the body's master regulators. What hormones are, they're chemical messengers that go throughout our body trying to influence our physical systems. And I have the little Wi-Fi symbol there because that's kind of the way to look at this is that, if you have a router or you have Cat5 going through your house, internet is basically sent to send signals out to other body systems. That's how you can think of this. And so we're sending signals that are going to affect energy, metabolism, weight, mood, memory, reproduction, sexual health, and bone and muscle strength. And so these basically set the foundation for aging. And so, when you have these chemical messengers influencing all these systems, you also realize that anything that affects that signal, whether it's the signal stops, say your Wi-Fi goes out, or say your Wi-Fi signal is just not as strong as it used to be, you can imagine that there's going to be an immediate or long-term consequence of that signal not firing. And so it's just an easy way to just kind of look at what happens and why we're trying to keep the Wi-Fi signal strong. At certain points of our life, we have to do a reset. We hopefully have that would be a soft reset and not a hard reset. But you're going to find that everybody is at a different point of hormone decline that will cause us to have to respond differently. But in most cases, it's just tweaking unless you let things get to a critical state. So let's talk a little bit about HRT and TRT. So HRT and TRT have been around for, well, at least HRT around since the 50s and 60s, and continued on through the 90s. And what hormone replacement therapy really meant was hormone replacement. And that was the idea of replacing hormones in the time of having symptoms when you're reaching menopause. So this was a very conservative approach to hormone replacement. And it's basically saying, okay, when women had symptoms or men had symptoms, we would replace that with conservative dosing of progesterone, estrogen, or testosterone. And the TRT kind of came off of that because after a while, andropause or testosterone deficiency was just kind of ignored because everyone was just assuming that HRT meant progesterone and estrogen. So TRT was kind of brought out to just say, hey, men, we understand you need help. And it was probably more of a marketing term than anything, just to separate the HRT and the TRT. But still, it was replacement. Is if you had testosterone deficiency and you were having symptoms, then we could consider giving you some testosterone, but again, conservative and narrow windows of dosing. But now in wellness and functional medicine, and it's this idea of optimization. And what's great about that is that now we're expanding and we're not just looking at replacing, we're looking at slowing the decline or reversing the decline and maximizing vitality. And so with optimization, we have more aggressive dosing, and we also look beyond the narrow windows of prescribing. And we also look at other hormones. We're not just talking about testosterone and progesterone and estrogen. We're expanding out into DHEA, pregnenolone, thyroid, growth hormone, and even peptide therapies, which a lot of people are hearing about. Peptide therapies are amazing because they affect neurotransmitters and they also affect hormones. But they're huge for a huge opportunity when we're looking at maximizing vitality. And these are things that aren't really considered in replacement, which is very conservative. So optimization is kind of the new term for what we're using in functional medicine. But it doesn't matter. So, our consumers are going to continue to think of it as HRT and TRT. They're not going to be saying hi. You might hear people saying hormone optimization, but just kind of use those together. But what we're really trying to do at this point, and when by the end of this conversation, you're going to see is that we're really trying to optimize, and we can't just focus on progesterone, estrogen, and testosterone. We have to consider the other hormones. So real quick on hormones versus neurotransmitters, since I mentioned it. Both chemical signalers in our body. You can think of hormones as more of a long-term solution. They're secreted from the endocrine glands and they go to the endocrine organs, the endocrine system to the endocrine glands, travel through the blood, more involved in longer-term processes. And then neurotransmitters on the other side are chemical signalers that are sent from neurons and travel through our nervous system and seem to act more locally and a lot quicker. But both of them are very vital and work together to make our body function. And they work off of each other and sometimes even overlap. But we're talking about hormones today, but there will be some overlap into the neurotransmitters. So what are the major players? We kind of spoken about them already, but estrogen, progesterone, obviously the main female sex hormones, but still involved in men's health too, which we'll talk about. Testosterone, the main male sex hormone, but also very important for women. We have growth hormone and IGF-1. Growth hormone is secreted by the pituitary gland, goes to the liver, causes liver to secrete insulin-like growth factor. It's IGF-1 that is really involved with most of the benefits that we talk about growth hormone, the anabolic effects, which there are a lot of benefits with growth hormone. And then thyroid hormones, which are kind of the metabolic regulators in our body. Adrenal hormones manages our stress, and DHA, pregnenolone, cortisol, all of these, which we'll talk a little bit more. But these are the main players when we're talking about hormone optimization. There's some other that decline with age. Thymosin's one of them, and working on our thymus gland and our immune response. So we do see an age-related decline in immunity. But these are the main ones that we're going to discuss. So where do our hormones go? That's a good question. Why do we need replacement? Why do we need optimization? And again, I put that little tagline up there. Aging is inevitable and decline is optional. It's because when we look at decline, we have to distinguish between normal and pathologic, and then we can start to figure out what we can do to try to slow or reverse it. So when we talk about normal hormone decline, what we're talking about is menopause and andropause. And so as hormones start to decline in our bodies, it starts somewhere between around the 30s, sometimes now earlier, but normally it's around the 30s. And what happens is, with men and women, you see this slow but progressive hormone decline over, a couple decades. Now, women tend to hit a brick wall, or kind of, they say, fall off a cliff with hormone decline with menopause, whereas men tend to have a much more slow progressive state of hormone decline. And that's why I think andropause gets left out of the equation a lot, is just because it's not as dramatic of a drop. But either way, it doesn't matter the timing or the path of how we get there. Men and women end up in the same spot. We all end up in a spot where we're losing cognition, we're losing muscle, we're losing bone, our metabolism slows down, our sex drive goes away, our sleep cycle is interrupted, shortens a little bit. So we all end up at the same spot. And so it doesn't matter how we get there, we're still dealing with a hormone decline. So now just imagine if you take normal hormone decline and you add some pathological aging or pathological decline on top of already declining hormones. And you can see how this could set someone up for a pretty aggressive aging and a high risk of symptoms and disease. But pathological aging is a little bit different because it doesn't have to be the same for everybody. And that's where that decline is optional is important, because with pathological aging, these are things that can be stopped, reversed, or prevented. So when we talk about metabolic disease, obesity, stress, toxins, blue light, even genetics and epigenetics, we all kind of get to the same point. So they all affect hormones, and they all affect hormone decline. But really, all of this conglomerate of conditions and exposures and all end up causing disruption of two main things of cause of disease, which is chronic inflammation and insulin resistance. You're going to hear this always, and it's never going to change. And that's why I don't think there's one treatment, one pill that can correct this. You can see this is a multitude of conditions that end up causing this pathological decline. So when you think about metabolic disease is just a cluster of conditions, from high blood pressure, high cholesterol, um, uh, 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 body composition, so a certain amount of obesity or truncal obesity or neck girth, and insulin resistance. And so when you have that conglomerate of conditions, and you have stress and toxins, and stress more than we've ever had, and now this blue light, which screen exposures, which we know are hormone disruptors, you can see you can start down this path, which once you get started on it, is very hard to get out of it. And you see on this side here, you have this path. Now, when we get done with to the end of menopause and andropause, and we're in this point where we have these other influences causing hormone decline, we get to this road where we're like, okay, well, this is normal aging. And so you can either decide to accept it, knowing all of the potential effects of hormone decline, or you can be proactive about it. And it's not just defining the end of fertility. This is discussing what your health path is going to be, how you're going to age, and what health status you're going to age at. And so adding this pathological component to it really brings things to light. And this is probably the most important slide out of the whole conversation, is what happens with hormone decline. And so when we get to this point of chronic inflammation and insulin resistance, this is such a big conversation, but I'm going to try to just give you kind of the normal path. And it's important for people to understand this because now it really sheds light onto why lifestyle is so important. These are preventable conditions that we can manage. And so just kind of take a look at the picture of when what happens. And so in society right now, we're overeaters. We consume more carbs than protein and healthy fats. We eat more than we burn. And when you add chronic stress on there, you know what chronic stress does is it causes our cortisol, our stress hormone, to be released. And what happens with our stress hormones released is it does its job and it's necessary for life. That is what it adapts to our external environment. And when you have cortisol secreted, it puts you in a fight or flight response. And when you have a fight or flight response, your body's basically getting ready to fight or flight. And so what happens is it's starting to tell your body to make more and produce more glucose. And all it wants is to have more energy and get your body in a position to protect itself. And so you add that on top of already eating too much carbohydrates and already having a body or a situation where we can't utilize all the energy all the food we're putting into it. So you now have a double result of over insulin production from the pancreas. Now you have this insulin circulating around. The cells, after a while, they don't respond to insulin the same. So now the sugar's not going into the cells the way it's supposed to, and it's circulating in the blood. When blood glucose levels rise, it starts causing inflammation. It starts causing other hormones to start shutting down, but it's the insulin resistance, the cell's inability to bring the sugar inside the cell that causes the problem. And so now you have all the circulating, your insulin rising, you have all the circulating glucose that you can't remove. It starts to create more of a vicious cycle by creating more fat tissue or visceral fat. And you get into a point where then the insulin is also causing the way estrogen affects thyroid. You get aromatization in the fat tissues and in the adrenal glands. Everything's in protection mode, and so it's affecting all the hormones. So now estrogen's going to go up, and the estrogen progesterone ratio changes. Testosterone in men in fat tissue starts to convert into estrogen, and you start getting men with estrogen dominance and testosterone deficiency. And these things will happen over time, but the more the pathologic decline, the faster these things are going to happen. And you just imagine that this is all silent stuff happening inside. It's not till the person actually feels these symptoms that they start realizing, wait a minute, maybe this isn't just normal aging. Maybe I have a problem. And then they go to their doctor. And of course, what's going to happen when they go to their doctor is going to run tests, but not run any hormone tests. And so they're not going to get any help until they find out someone that's going to evaluate their hormones, but that hasn't happened. So that is why advanced aging happens, and that's why there are a lot of people out there that are just stuck thinking that this is just aging and they can't get rid of the obesity. They can't get their brain to give them motivation and help with reward and discipline. So it's a big vicious cycle. And down at the bottom there, abnormal age-related decline is just that all these things that we're seeing that were normally in the 30s, 40s, and 50s is now starting in the 20s and 30s and 40s. So just drop a decade, and this is what's happening. We're seeing young men with erectile dysfunction. We're seeing women with, early menopause in their early 40s. We're seeing hormone imbalances and hormone decline in the 30s. It's a lot of the hormone related symptoms are starting at early ages, and this is a concern, and obviously why we're excited to have this conversation, because the generations behind us are in for an awakening, because you know the signs are there, and we have to do something about it, because and if we don't start bringing up this condition of this vicious cycle of pathological aging on top of normal aging, we're in for a crisis. So why does this matter? So we just talked about, the problems with hormone decline. Well, it's hormone decline is tied to cardiovascular disease. That's one of the big things we'll talk about in the World Women's Health Initiative, osteoporosis and fractures, metabolic syndrome and diabetes, cognitive decline, low libido, and sexual dysfunction. And so, like, one of the things is cognitive decline. When we talk about, people getting into this situation and then, really eventually trying to almost attack their character, saying, "Oh my gosh, I know what I need to do. I just feel like I shouldn't be in this situation. I don't understand. I just can't I can't get out. I'm just stuck." And it's because the same thing that's happening to our bodies is happening to our brain, in our mind. And so just imagine these hormones that are supposed to be influencing our brain and also causing neurotransmitters to give that immediate reward are not firing the way they're supposed to. So it's not that, people should be taking this as an attack on character, but rather understand that this is a biochemical decline. This is a chemical situation that they're in. And if they don't take an aggressive stance by evaluating and getting their hormones checked, but also including a lot of lifestyle factors, they're not going to get out of it. But the whole part of mindful medicine and understanding what got us there. I mean, you can talk about all the age-related issues that are causing younger generations to suffer from hormone decline. I mean, we already talked about blue screen, but we got food, our food processing, our over processing of foods, our sedentary lifestyles. You can even throw in there just our lack of being outside and being connected. Right now they say about the average American adult spends about 8% of the time outside. That is supposed to start going down to potentially 3% in the next 20 years. Just think about that. We spend 8% or less of our time outside. We don't get enough sunlight. We're not grounded enough. We're not out in nature enough. And all of these things do affect our well-being. So, and then down at the bottom, libido and sexual dysfunction. Yeah, I mean, that's one that most people recognize with hormones. But again, you see on the side here, we have decline versus vitality. And this is the discussion, is that we have normal and pathologic decline, but this is also, if you can do anything to slow this down, that is what's going to lead to vitality versus advanced aging. So this slide just shows the various categories and then what happens with accelerated aging. And then on the opposite side, it's just showing you what vitality and longevity would look like. And I just talked about brain fog and cognitive decline, but you look at lean muscle mass and bones. There are studies now supporting that sarcopenia, which is the age-related muscle loss, is probably the number one way to look at longevity. And we are losing muscle, from the age 30 onward is a constant decline of muscle mass. And one of the things that maintains muscle mass is hormones, testosterone, estrogen in bones, and growth hormone for protecting our muscles and bones. So all of these hormones start to decline, and the faster they decline, the faster you're going to start losing muscle and bones, which is directly tied from research on longevity. We already talked about thymosin and in being immunocompromised, but just remember, in a state of chronic inflammation, you are using all of your resources to fight inflammation, which leaves our immune system vulnerable to other conditions which normally would be functioning, but they just don't have the resources. So, of course, the body goes into protection mode, and it's going to start working on other areas, key areas in key systems, and it leaves the immune system in a vulnerable state. So this is one that you guys can just look at later, but it kind of explains really just changing everything from accelerating age to slowing down and potentially leading to vitality and longevity. So let's talk about women. So when we start getting into the key differences between men and women and hormones, I love working with women. I love helping women. It would be easier if I was able to be a woman for a short period of time to understand what a hormone cycle felt like. In my years of medicine, I've tried pretty much every single therapy other than female hormones on myself, and I always do that. But this is just one that's not easy to put yourself in the position of, but I can tell you there is a difference. And so when you look at women and in the way they deal with hormones, I mean, from menarche all the way to menopause, they're dealing with hormone cycles. So you got to think about it. Their hormones are cyclic, they're very dynamic, and they're extremely vulnerable. And so it becomes very obvious why there's several disease processes that are gender dominant in women. But when you kind of think about this, their whole life cycle up until menopause is just a constant cycle of hormones, which equals is a direct correlation to stress. So, it immediately puts women, when they're dealing with these cycling hormones, progesterone and estrogen, in this fine dance every month, and the effects of other hormones trying to balance those changes. It affects bloating and gastrointestinal system. It affects the mind, the mood. It affects lean muscle mass, obviously reproduction, but I mean, it's just a very complex system. And so when we understand that, and we understand the timing of perimenopause versus postmenopause, it's very easy to start understanding that when you have these type of cyclic changes and these dynamic changes and the very vulnerable nature that women have, because just small little changes in hormones can throw off the whole cycle, which can lead people to a whole month or 2 months of trying to just get back onto regularity. But during that time, they feel miserable. I mean, you can talk about menstrual migraines, the dominance of irritable bowel syndrome. These are things that can happen on a monthly basis. And just think of the stress that puts on people, because they're also trying to deal with the social pressures of being women. So there's so many women in the workforce. They're dealing with children, they're dealing with work, they're trying to still look good, and all the pressures of being a woman and being successful, and both being productive, but also being presentable. And the social pressures cause women to almost be on a diet nonstop. And the and when you think about that, it can get really hard for women to really understand how to diet correctly, the importance of the nutrients, importance of hormones, especially when hormones aren't discussed with in most primary care settings. So you take the social pressures, you take the normal age-related decline, the cyclic nature of it, and you put yourself in a higher burden of disease. And that's the whole point of hormones in women, and why HRT was the first thing that came out, was because we know the cliff that, and you can see it in this picture, the woman sitting on the, I don't know how to go back, but oh, here we go. Sorry. Oh, anyway. Well, anyway, I'll go back to that. But you can understand the cyclic nature of their hormones, that it puts them in a lopsided disease burden. And when you balance hormones for women, you can actually, just that stabilization or anchoring their hormones kind of levels that playing field, because right now women have a 80% higher risk of autoimmune disease. They're 80% higher risk of thyroid disease. They dominate dementia. They dominate mental illness. And by managing their hormones, that can at least try to level off the playing field somewhat. So anyway, so now we're over to men. We'll talk a little bit more about the overlap of men and women, but let's just get on to men. So now with men, hormone decline is more gradually. You see the hill here with the men symbol. We already talked about that men's testosterone gradually declines. They don't face the same type of progesterone estrogen cliff. It's just not the same. The aging's not the same. And, there's always the little joke about that men can lose weight by just thinking about it. Well, there's reasons for that. Remember, we just gave a ton of ammunition for women to be able to make their case on why they have a little bit more difficulty in a lot of areas, especially weight management. But so their hormone decline is more gradual. They don't have to deal with the cliff of progesterone and estrogen, but progesterone and estrogen are very important in men as well. You have estrogen that's still important for the brain, still important for the bones in men. And progesterone is kind of the balancer, and how it works on the prostate and the brain as well, balancing the effects of estrogen in men. But most importantly, andropause is about testosterone. And in a lot of cases, andropause and testosterone deficiency is ignored. If a doctor's not going to bring it up to someone when they come in and saying, "Oh man, I'm just, been tired, just not feeling well. I just got brain fog. I'm not sleeping very well. I've been noticing that I'm losing my muscle mass." They're going to say to change your diet, work out more, get better sleep. But to actually bring up that, hey, this could be your testosterone, isn't happening. And so there's all of these men out there that are suffering this slow loss of testosterone. And now when you talk about the pathological causes, some of these men are starting to lose their testosterone in much earlier age. So we're going to start seeing both primary and secondary hypogonadism, gonadism on the rise. And TRT can completely change a men's path, completely restore vitality, their confidence, and performance. And you see that spot where it says it's not just sex and muscles. This is something that that involves much more than that. You know, when men come into and talk to me about testosterone, most of the time when someone goes on testosterone therapy, libido and sex is at the bottom. You know, one of the main things is energy. Mood is another one, sleep is another one, and then you start getting into libido and lean muscle mass and body fat. But you know, so it just shows you that it's not sex and muscles. People, the number one complaint is energy. Guys just come in and they just hit a wall. They just do not feel as good as they used to. You restore their testosterone levels to physiological dosing. Next thing, their energy goes up, their mood goes up, their confidence goes up. And yes, of course, it can touch with both men and women into sex and libido and erectile function, but that's not the primary goal. So the overlap. So both men and women are susceptible, and we know that. It's pretty obvious with the cliff and the hill that we just reached the that endpoint a little bit differently, and obviously the decline or the abrupt stopping of estrogen and progesterone can be very different than the way men approach andropause. But it's not just progesterone, estrogen, and testosterone. There's some other key hormones that we must talk about that also decline with age that are very key for both men and women, and that's thyroid, adrenal hormones, and growth hormone. So we talked a little bit about thyroid, and thyroid is just kind of that metabolic regulator, and that is what is very. And another thing when we talked about why women are more susceptible to thyroid disease is because estrogen, that sharp estrogen decline, whether it's in pregnancy or whether it's pathologic or whether that it's in menopause, can affect the thyroid binding. And so what happens is it leaves women much more susceptible to thyroid disease. And this is a great point to talk about treating within normal ranges. So a lot of men and women will come in, but mostly women with subclinical hypothyroidism. And what that means is that they went in, they had all the tests done, and either maybe they're really at the bottom of normal range, or their labs come back pretty much normal, and they're just been told to say, hey, you know, your thyroid's normal. You know, sorry, you know, just keep working on your lifestyle. But there are a ton of these women that have so many of the symptoms of underactive thyroid, and if you were able to look at their thyroid panel and you look at their and your free T3 and free T4 and even reverse T3, you can see that there is plenty of opportunities to optimize the thyroid within normal ranges. And that subclinical hypothyroidism can completely change a woman's path. They can come in and have all of these symptoms, and you don't even touch progesterone, estrogen, or testosterone or growth hormone. All you do is make a slight adjustment in their thyroid. So when they come back in and you check their labs again and you say, hey, how are you doing? And they go, I'm doing amazing. I can't believe how much better I'm feeling. You look at their hormones, and guess what? They're still in normal range. So all you did was take their low normal to a mid to high normal, which is still normal range, and you completely fixed all of these symptoms as this woman had. And the symptoms are terrible. It's low energy, it's brittle hair, it's you know, brittle nails, mood, depressed, you know, lack of libido, lack of motivation, and just one hormone can completely change that path for that woman. So when you get into adrenal hormones, it's the same way. When we get men and women come in, when if you know, again, women dominate you know, these complaints, but when men come in, same thing. Both men and women, when they're at a point where they're fatigued, they're muscle loss, they're not sleeping, they're depressed, remember, inside there's a lot of activity that has already been going on. So they're coming when they're at the break point. So all of this change has been going on internally, you know, chronic inflammation, insulin resistance, hormone decline. And now you start looking at their adrenal hormones. And most of the time, DHEA and pregnenolone are very low, sometimes negligible in women. It's because these hormones are involved in the stress management, because adrenal hormones also include cortisol. So you have pregnenolone that basically feeds the production of both DHEA and cortisol. And so pregnenolone is kind of the mother of all hormones, which declines just because it's feeding these other two hormones. But DHEA and cortisol are actually looked at in a ratio. So you're always looking at your cortisol to DHEA ratio to actually see how your stress response is. Because DHEA kind of is used to, it's kind of the youth hormone, which is used to balance out the stress response that, continual cortisol will provide. So all three of these adrenal hormones are extremely important, and you can optimize them. These hormones decline with age, so then you add on pathologic decline, and these hormones, although not talked about very often, are so important for the mood, for metabolism, and to also support, the chronic stress and the whole stress response. Then we have growth hormone. So growth hormone is one of the important hormones. This came out a long time, probably in the early 2000s, where growth hormone really started to make the news, and that's because growth hormone declines very aggressively for some people, but consistently over time. I think it's less than 50% of it by the time you're age 70. So with growth hormone, that is what causes lipolysis. It causes improvements in circadian rhythm. It helps with our insulin sensitivity. It reduces inflammation, helps with lean muscle mass, helps with mood, cognition. It's one of those that you can imagine is, you like to think of it a magic pill, but it is definitely one of those hormones that can make a major impact, potentially even more than testosterone, progesterone, estrogen by themselves. And so with growth hormone, we also have to realize that our pituitary gland is aging as well. And so our own growth hormone production and secretion is going to go down, which is why it declines with age. So growth hormone therapy is important because that bypasses when you use human growth hormone, it bypasses your pituitary. You don't have to rely on the pituitary. You're just giving growth hormone, which again then has to go to the liver, and then the liver secretes insulin-like growth factor, which really gives the effects. So on top of that, you also have to consider that you're looking at the nature of your liver to also be intact, because growth hormone, if it goes to the liver and your liver is not functioning well, if you have cirrhosis or any other fatty infiltration of the liver, you're not going to put out growth hormone the same way. And so that brings up another hormone called insulin-like growth factor that you can actually get this as a peptide, and you're basically bypassing the full system at that point and just giving insulin-like growth factor, which I've had to use for some people that do have chronic liver disease. I've had a couple patients with chronic cirrhosis, which insulin-like growth factor kept them, their vitality as high as it can be for many years, when they were told that they would likely not make it past one or two. So sexual health and quality of life, we know that that's a big part of this. We've talked about it in both sexes or both genders. We're going to realize that giving progesterone, giving estrogen, and giving testosterone can help with libido, help with confidence, help with the whole path of better body composition, which obviously makes you feel to be more sexual, and obviously can help with sexual performance. Down at the bottom, I talk about what if, and what if is the conversation that's going to be talked about by a lot of men and women over the last 20 years that had not been on hormones, where now you're going to start to see the conversation of hormone therapy coming out. But the what if is, what if if I would have started hormone therapy back when I was 35, when I started to feel sluggish, or, what if I had my hormones checked? And it's an unfortunate situation, but what we don't want to do is continue to have the what ifs. Now that we're knowing this information and the rest of the information we're going to talk about, we don't want to have what ifs. We want to test, and we want to find out if there is a solution. We want people to not sit and wonder what if they would have done something earlier, what that path would have looked like for them, where that would have led them. Would that have prevented some of the disease that they had in the future? So that's what we're trying to prevent with all of this, and both sexes need it. So routes of therapy, I'm going to start picking up the speed a little bit here. So we have injections, pellet, creams, gels, patches, and oral. It's pretty easy to start thinking about routes of therapy, but you do have to consider cost. There are needle phobic people out there, but overall, we're talking about getting the best bang for the buck. And in hormone therapy and in wellness, in functional medicine, a lot of the therapies that we prescribe are by injection. And that's just because you're getting close to 100% availability. You're bypassing the liver metabolism, the first path effect from the gastrointestinal system, and it's just more reliable. So a lot of the stuff is done by injections, but when we have to do injections, it's most of the time it's not every day, almost never every day, and a lot of times it's weekly injections. But there is a reason for using them when you're talking about availability. Pellets is something in my career I've looked at them, I've thought about them, but it's never been something that I really felt was appropriate. And if you're a physician on here that's doing pellets, just don't take this the wrong way. It's just in my career I have helped so many women and some men, but mostly women, get off of pellets because you can imagine. Pellet therapy is expensive. It's a little bit more invasive. We've had people that have pellets have protruded through their skin, but we've had multiple women that have had very concerning responses to pellets. Some people have ended up in the ER with anxiety attacks, or we've had people with various side effects from too much hormones. Because when you put pellets inside the skin, you're assuming that everyone's going to metabolize and break down those pellets and release hormones at the same pace. But what happens is the pellets cause a hormone spike, and then that spike slowly starts to go down. You feel good in the middle, and then you're into a deficiency state again, and then you're having to get pellets put back in. They're more expensive, but I like using therapies that you can change on the fly. You can get expected results, especially for women. When we talked about how vulnerable they are to change, it's really hard to nail down a woman. It happens, and there are women out there that love pellets, but it's a small percentage that we've seen in our practice. Men, we do see men that are happy with their pellets, but again, I like control. I like to be able to make changes if people have side effects, if they have complaints. I don't want to sit there and have to wait. Creams, gel patches, just not as effective. Sometimes with hormone creams, you also have to consider cross-contamination. These creams are on your body. There have been documented cases where these creams have touched kids or partners and causes hormone changes in them. And then when we talk about oral, yes, in select cases, that's your only option, but just realize the bioavailability is somewhere between, 10 to 80%, but most of the time it's, 20 to 40%. And you're dealing with the first pass effect and then high liver metabolism. So most of the time we're talking about injections, but, this is something that's going to be very physician or provider specific on what they want to use, but just do your research. So bioidentical versus synthetic, of course, in a perfect world, everything would be bioidentical, and that's just recognized by the body as natural. It's the same receptor sites, it's the same compound structurally. Obviously, that seems to be safer with fewer side effects. It's definitely preferred in functional medicine. It's just not an option in a lot of cases. But when we're talking about estrogen and progesterone and testosterone, there are some bioidentical options for that. It works great with estrogens and progesterones. Testosterones in women, they can get a benefit, but I have not had any men that have ever tried bioidentical testosterone have the response that they're looking for. But we do use bioidentical as much as possible. But some of the synthetic versions of hormones, especially the microprogestins and the estrogens, are just ones you stay away from. That's where you're going to start getting much higher side effects. The body just does not understand understand them the same way and don't respond to them the same way. But just realize when something isn't available bioidentical, it doesn't mean that it's not going to work. It's just not going to be recognized the same. But in a lot of cases, when synthetic hormones do go on the body, they are recognized the same. And that's the part which you leave up to the providers. But just remember, when you're talking about the female sex hormones, there are bioidentical options that work very, very well. So monitoring and safety. So lab data and tracking, for us, we look at two things. We look at objective data and subjective data. So the objective lab data is important. Obviously, this is the way we're going to get our initial information, and then we can track that over time. But as you can imagine, when you're doing things proper and you're dosing things proper, The lab data is a little bit more predictable in most cases. But what becomes really important is what it's doing subjectively. How are people feeling? And this is what we need to track. And this is what people have to come into and tell us is, so when we normally take a new client, we do lab data, and then we usually do a follow-up panel at 3 months. So at 3 months, that's usually the amount of time where the hormones that we are optimizing or replacing have a chance to actually make an impact. You can't have someone come back in a month because most of the time that's right when they start to feel better. So at 3 months, we have someone come back, and at that time, if things are looking good objectively, subjectively, they're doing well. We might not see them or do another lab panel for another 6 months. It depends on the person, but that's kind of the approach we take. We're very into how people are feeling and how they're responding, any side effects, what's improved, what hasn't improved, and you can make little tweaks. That's another reason why we don't use pellets because we can make changes on the fly. This is individualized care. Not everybody is going to get the same treatment, the same hormones, because everybody's lives are different. But you have to know that the proper dosing and monitoring. Just if you're interested in starting hormone therapy in your office, there is there is some pretty consistent ways you can approach this. So there is kind of a blueprint for hormone therapy. So you're not going in going, oh my gosh, every person is going to be different. What do I do? There's a pretty standard approach that I have to men and women, depending on if they're younger men and women. Are they menopausal and andropausal men and women? Are they post or menopause or andropausal men and women? And there's an approach that you're going to have for them. And that's what's nice is that once you kind of get into the groove, you're going to treat most of these people the same way because you can always go up. So when you're doing proper dosing, proper monitoring, listening to people, telling them that, hey, we got plenty of time. This isn't a sprint, it's a marathon. Let's just start with this. Let's see you back and see how you're doing. We can always adjust. If after 6 weeks or so you're just not feeling anything, give us a call and we'll make some tweaks. So that is the good news. Just know that you can. It isn't as complex as it sounds, and can be done so that you start getting into a rhythm where every person comes in, you kind of have an idea of what to expect, and then how you're going to start them out. All right, 9 minutes. All right. So what happened to the 2002 World Health Initiative? This is what just happened recently. I gotta have to pick it up a little bit here. I apologize. But what this did was, so we talked about how in the HRT was discussed in the 50s and 60s all the way through the 90s. And in the 90s, there was 30% or so of women were on hormone replacement therapy. There was a 5-6% of men at that time, but remember TRT didn't really start picking up steam until the 2000s. But this study came out in 2002, and it basically just hit the brakes on HRT. And that's both from a consumer standpoint and a provider standpoint. Doctors were scared to prescribe them. Consumers were afraid to take them because it linked HRT to breast cancer and cardiovascular disease, specifically stroke and heart disease. So what happened just in the last 4 weeks or so, 6 weeks, is that they came back and they reevaluated the study and found that there were some unspoken study flaws that they knew. I knew of this in 2002. We were already talking about the flaws, but this didn't make mainstream media and is a great example of how you are only going to hear what you are to hear if you're listening to the news. But they finally came back and they started speaking about the study flaws, which the brunt of it is that the average age of the woman was 63. So these people were already 13 years past the average age of menopause. And they were using microprogesterone and or synthetic versions of both estrogen and progesterone, both linked to increased cancer risks. And so what that did was put fear and misinformation, and it left decades of women in the what if state. What if I could go back and do that again? But here we are now, able to go forward. We understand now that they've removed the black box warning on testosterone for both men and women. Now they're saying that testosterone therapy in men and women can have a potentially up to a 60% reduction in heart disease. And they're even talking about some topical estrogens having no risk of cancer. So again, there's more to come, but this is just really good news for us that to support what we want to do with hormone therapy. So what can we do now? Stick to the facts. The risks were overstated, the benefits ignored. There's functional medicine proof. I told you I've been doing this since 2002. Cenogenics came out and started really making momentum and around the same, the age management, A4M and the age management medicine came out in around the early 2000s, but Cenogenics was open since 1997, and that was operating all the way behind the scenes. This small group of doctors were using hormones from the beginning with great results and great response. But it was a small group of people that did the research, were educated, and were saying, hey, you know what? I got to find someone to help me with my hormones. I'm not listening to this. It doesn't make sense, or knew that the studies were flawed. But this was all happening in the background. So there's functional medicine proof. These clinics and our patients weren't dying of cancer and heart disease. They're thriving. And so when you kind of look at that, this was all happening behind the scenes, it gives you your confidence to say, okay, well, this is safe. So especially when you use bioidentical and you start with earlier use, especially in the testing in the early to late 30s and especially in the 40s, and then definitely as people are coming out of menopause, you want to start earlier, and there's better research to show how they're much more safe and effective. But this is great. This is exciting for medicine. Right now, medicine needs this. We're facing almost rise in every category of disease. They might tell you that heart attacks are down in both genders by 1.7% or 3%, but in general, all disease is on the rise. We need something to help slow down this progressive movement of disease, especially for brain disease. When we're talking about dementia and mental illness, which are higher than they've ever been, suicidal ideality, loss of muscle mass, osteoporosis, neurodegenerative disease, all these diseases are on the rise. And now we have a great new exciting news that we can have new tools to potentially mitigate that. So what you do is you just use education and support. You use this information you have to start seeing how you can make changes for the people around you, and for yourselves and for your clients, and just start to at least consider this as an option based off the information you heard. Now, you can see I could go much deeper into all of these hormones and even make more sense of all this, but this was just supposed to be an overview of where we're at and what hormones can do for people and what hormone decline causes as far as aging. So missing misconceptions, real quick. HRT TRT causes cancer. You can dig deep into this again. Remember, this has all been going in the background. Our clients, if there was a distinct rise in cancer from using HRT and TRT over the years, we would have known about it. Again, what you're seeing from that one slide that I talked about, normal decline and pathologic decline, what causes cancer is inflammation and insulin resistance. It's chronic inflammation, it's environmental exposures, and it's genetics and epigenetics. And epigenetics, again, is going into environmental exposure. This is what causes dysplastic cells. This is what disrupts the way that we make and the way we conserve energy. And when we're in an energy deficit, our immune system cannot do its job. There's a thing called autophagy, which is a direct immune response on how we can clear the body of dysplastic cells. And when your energy is used for vital organ systems and just to get your normal autonomic nervous system to work, you're seeing that the energy is not available for key immune functions. That's what causes cancer to come out. That's what causes autoimmune disease to come out. And that is the leading causes of cancer. So we can't directly say that and brush under the carpet the pathologic causes of decline and just focus on HRT and TRT or various hormones and their potential link to cancer. We have to focus on what we know. Hormones are just for vanity and sex. That is not true. Yes, it infects it, I told you, but really what you have to look at this is that the hormones that help support in slowing the decline and slowing the symptoms and disease are the exact hormones that also give us the aesthetics and the libido. So it's like a byproduct of good living and good hormone optimization is vanity and sex. So it's not just vanity and sex, it's a byproduct. We're really trying to prevent disease. That's just an extra. It's the same medicine. The same thing that we're doing to try to prevent disease is the same thing that improves vanity and sex. Once you start, you cannot stop. That is also not, that is a misconception. There are plenty of people that are on their path of aging. They're overweight, they're not sleeping well, they're not exercising, they're not eating well, and they start doing these things along with hormone therapy. Over time, their hormone needs are going to change. And sometimes they change a lot, sometimes they change a little, but it doesn't matter. You know, if you're getting someone that their vitality and their drive is back and they're feeling amazing, if they still need to stay on hormones, guess what? They're going to stay on hormones, but they're doing it in a proper way, a safe way, and in a monitored way. So you don't need hormones until you're older. We already talked about that. That's not true. If you're having symptoms, do not wait. Remember, do not be subjected to having all of this internal struggles and hormone decline and inflammation and insulin resistance just percolating without you recognizing it. So as soon as something is off, as soon as you don't feel right, and you've made the lifestyle changes, then it's hormones. So get your hormones checked. And we already talked also is that this is happening in a younger and younger age. So this is no longer a midlife crisis, a midlife situation. This is something that's happening in the 20s and 30s and early 40s. And so you know when you have those younger people coming in, don't just think that it's not hormones. Again, we're treating 20-year-olds, mid 20-year-olds for erectile dysfunction. It's a little bizarre and a little scary, but that can at least change the way you're approaching some of these younger individuals with these types of complaints. So key takeaways, message should be much clearer now. Hopefully you guys understand between the redacting of the World Women's Health Initiative, understanding how hormones affect aging, pathologic decline. Hormones are the cornerstone of longevity medicine. I wouldn't have the results I did from all the patients I have if I weren't dealing with hormones. Again, testosterone, progesterone, estrogen, DHEA, pregnenolone, growth hormone, thyroid. Um, you know, we manipulate all of these hormones depending on the individual. The 2002 study created decades of confusion. That's been reevaluated. We understand that hormones are safe, effective, and underutilized. Medicine needs help, as we talked about. Do not ignore hormone decline. Make sure you get educated. Encourage an open dialogue with providers and with your patients so you can learn. You know, this industry is neat. It's a very neat group of you know doctors that are in functional medicine. We all want to help each other. We want people to understand the importance of this because it's our friends and family. They're the ones out there that are suffering, and we just need more doctors to understand this opportunity. And then the last is just emphasize prevention and vitality. Remember, they're the same medicine. So I think that is it. And then I think Shelley's going to talk a little bit about.
Hello. All right. So the presentation today was just like Dr. Agin said, it was like basically a generic overview to kind of give you guys some information. But we do have a training on our website, mypracticeconnect.com, that you can go on, and we have some codes available. We'll also send this out in an email after, but the training does include 6 months of coaching from our medical team. It's a wonderful way to kind of dive deeper into hormones and how to incorporate that into your clinic. It's very clinical, so you're going to learn about it versus just learning about the subject. So it's a great course. We also have other trainings on there as well. We also have our platform. If you do not have a platform and you want to learn how to learn more about this, we have a little video on our website as well that kind of shows you and walks you through the DEA certified e-script platform. We have lots of bells and whistles on there currently, and we have a lot more coming in 2026. That's going to really change the landscape for providers to be able to use our network of providers and our consultation module to be able to do consultations, as well as be able to do them in states they're not licensed in, because we have that network available for you. Anyways, I think you can read through everything here. Just wanted to kind of put this out there for you. We have we're constantly changing and upgrading our platform and our trainings to meet our providers' needs and the suggestions there. So with that, we're kind of a few minutes over. I don't see any questions in the chat, but if anybody has a question, feel free to throw it in the chat or unmute yourself.
Must have been such a thorough job.
You did a great job.
So it's just a lot of information. So again, I apologize. I felt like I rushed through that, which I had to, because I wanted to get out as much information as I could. But hopefully you got an overview of where we are, where we came from, and the opportunities we have ahead. I strongly suggest, if you're not doing any hormone therapy, to dive into this. This is the opportunity. You're going to get more and more clients coming in and asking you about hormones because of this information that's been finally reached in, or unleashed into the media. So don't run from it. Try to get educated and try to see how you can add this to your practice, because you will change a lot of people's health paths for sure. Thank you, everybody.